All right. Take two. This time it's working. Hi, guys. It's Danielle at Your Life of Stewart again. Today we have the pleasure of having Dr. Turgeon in again to speak to you all. A different topic this time, and he'll explain that. And of course, he is the medical director from Vitas Healthcare. If you have any questions, feel free to post them during the chat, or of course, you can go back on later. The video will stay on Facebook, and we will get back to you with any questions that you may have. All right. Thanks so much. Enjoy.
Thank you. Okay, we'll trade places. Good afternoon, and thanks for coming back. Again, I'm Dr. Turgeon. I'm the medical director for Vitas Health Services. And for those of you that tuned in last week, we had a discussion last week regarding two topics. One was heart disease, and the other was dementia. And we talked about how the two often intertwine and how one can affect how the other is being treated and managed. I wanted to do some additional expansion on that topic today. We're going to look today at how patients with underlying advanced lung disease can have their management affected if they also have an underlying dementia complicating their health condition. So we'll spend a little time talking about that. I will just very briefly review, a few of the statements that I made about dementia last week for those of you that didn't tune in. We know that dementia is the fifth leading cause of death in this country for patients over age 65. We know that most of those patients, or the majority of those patients, but certainly not all, will have a dementia that appears to be very much consistent with an Alzheimer's type of diagnosis. A number of other patients will have a dementia that is secondary to underlying heart disease, high blood pressure, recurring strokes. Some patients will have a dementia related to a condition we call Lewy bodies disease, Lewy body dementia. And there are many other causes that we've recognized. And we know that that about two-thirds of all patients with dementia, as the disease progresses, will no longer be able to remain at home. And we know that about two-thirds of patients with dementia actually die in a nursing home type setting, either a memory unit setting or a long-term care nursing setting that becomes their home for the last segment of their life. So now I'm going to talk a little bit about patients with advanced lung disease, and I'm going to tie that condition into those patients that also have an underlying history of dementia. When we look at patients with advanced lung disease, as their disease progresses to the point of causing their death, this makes up about the third leading cause of death in the United States at this time. We know that lung disease occurs more often in women than in men. The numbers are high in both, but in women, we believe that increased occurrence is both related to hormonal issues with the effects of estrogen on their lung tissue, and we believe it's also related in part just to the difference in lung volume and the difference in the anatomy of the female chest as opposed to the male chest. We break we break lung disease in general into two broad types of disease. And the simplest way of looking at it is those patients where air can't get out of the chest, and we call that obstructive lung disease. And that is the most common cause of, or the most common type of lung disease that we deal with. And then we talk about those patients where the air can't get in to the lung. We call that restrictive lung disease. And if we give you some examples of each, a very, very common term that we hear in medicine and in general population is COPD, which stands for chronic obstructive pulmonary disease. And this is by far the most common cause of advanced lung disease that we see in this country. Some other causes would be asthma or a condition we refer to as emphysema. And I personally believe that emphysema and COPD are very closely intertwined, as I think it's very, very, very similar components to both of those diseases. So that comprises, when we look at the large number of patients in this country, about 15.7 million patients in this country are diagnosed with COPD. So that's a large number of our population. If we look at restrictive lung disease, these are the patients where air can't get into the lung. The most common disease that we deal with is called pulmonary fibrosis. And those patients comprise about 140,000 patients in this country currently. And there are many causes for pulmonary fibrosis. Some of those conditions may be related to environmental exposure. We know that patients who have had past exposure to asbestos may develop that type of a lung condition as they age, and so that can be one of the causes. There are a number of chemical exposures that can also cause not only obstructive lung disease, COPD patients, but can also cause restrictive lung disease. When we look at COPD, again being the most common lung disease we deal with, the most common cause for that condition is the patient who smokes. We know that that is by far the largest cause for COPD in this country. And that is followed probably by work-related environmental toxins that patients inhale as part of their exposure. Now, hopefully, with all of the environmental protection initiatives that have been put in place by the government over the last few years, the environmental exposures on the basis of occupational exposure hopefully have become less of an issue as we go forward. So those are kind of the basic comments on that. So what are some of the symptoms that we deal with in patients? What are the symptoms that we expect patients to experience with advanced lung disease? We know that the most common symptom that patients experience is shortness of breath. We call that dyspnea, and it's shortness of breath. In the less severe cases, it is primarily when the patient is active. When the patient becomes more advanced with their disease process, that shortness of breath can occur at rest, can occur even with the patient talking to me. We know that patients often develop a cough, and the cough can be very disabling for some patients. They'll feel a sense of tightness in their chest, oftentimes associated with a cough. Patients often experience extreme symptoms of fatigue and generalized weakness. They oftentimes will develop muscle wasting associated with advanced lung disease conditions as well. And as their disease progresses, they often become very much impaired with their appetite. They tend to lose appetite. This only accelerates their overall decline because they're no longer able to maintain the nutritional support they need to maintain their lung health. We know that the impact of lung disease in a patient's life is substantial. And when you talk to patients with advanced lung disease and find out what are the symptoms that are most prevalent, that are most bothersome, that most negatively affect how they function on a daily basis, almost half of them will tell us that their most severe issue is cough. And others will tell us, a slightly less amount of patients will tell us that the most severe disabling symptoms for them is the actual shortness of breath and their sense of overwhelming fatigue. So these are some of the things that can very definitely impact how a patient's quality of life is perceived with this disease. When we look at the burden that COPD patients experience as part of their disease process, the burden that it has on their life, we know that about 70% of patients, as their disease becomes advanced, will know that they're no longer able to perform their normal daily activities. Their normal activities of life are severely impaired. We see these patients, when I see these patients in my practice of end of life care, hospice care, I will see that a large number of these patients, well over half of these patients, are no longer able to leave their home because of the impact of the shortness of breath and the breathing difficulty they experience. About 56% of patients will no longer be able to do even their simplest of home chores. They become largely bed to chair bound. Their social activities sort of go by the wayside. They're no longer able to go out and socialize with family and friends. So people have to come to them, and it gets to be a burden for people, for them to have people even come to them. We know that COPD has a very negative impact on our workforce and on the patient's ability to work. About 51% of patients, as their disease becomes somewhat advanced, even when they're still in the working force, will find that they have significant negative impact on ability to go to work. There's actually the numbers when we looked at in 2018, 2019, $3.9 billion was basically lost due to worker absenteeism in the workforce. So that's a significant hit. We know that 16.4 million lost workdays per year. When you cumulatively add up the number of patients with COPD that are still working but are not able to attend their work job because of their disease process. COPD, as it becomes advanced, significantly impacts the patient's ability to enjoy family activities as well, simply because they're just too weak, too fatigued, too symptomatic to consider doing these sort of activities anymore. So those are just some of the burdens that we look at, with these advanced lung patients. So what are some of the treatment options that we look for? I'm not going to go through specific drugs and specific treatments, but I will initiate this part of the talk by saying that though we have many medications out there and many medications that have been released in the last few years that have advanced our treatment of patients with lung disease, there is no treatment that will stop the progression of this disease once it starts. There's nothing that we can do to cure this or to reverse it. I found when I was reviewing some of the literature before putting this talk together, I was very surprised by one statement that repeatedly popped up in the literature, and that is that approximately 50% of patients that have pretty significant lung disease are not aware that they have it. Now, as the disease progresses, they're going to become aware because it does progress. So what are some of the general things we can do? We have many medications that will help to dilate the airway, the passages, the air passages. We call these the bronchioles. And there are many bronchial dilators, are what we call them. These are medications that we administer. Most of them we administer via one form or another of inhalation. So if you know people that have advanced lung problems, you know that many of them use what we call puffers, which are little portable containers that contain medicine that they can inhale into the chest and get hopefully immediate relief. We use a number of medications that are what we call nebulized. We have machines that will cause the medication to become a mist, and then you will inhale the mist into your chest, and this will help to dilate the airway passages. We have a number of medications also that reduce the inflammation that oftentimes occurs in patients with lung disease. There's a component of inflammation that occurs with COPD, and as a result, we oftentimes put patients on steroids to help with their breathing issues. Beyond the medications that we use, we also use machines to help patients many times. You may have heard of people that talk about using a machine called BiPAP, which is it's a machine that will help their lungs to expand and help push air into the lungs as a patient is attempting to breathe. And many of our patients, as their disease becomes more advanced, they will start to use these machines, especially at night, because at night when they go to sleep, their breathing effort tends to become a little more impaired, and so the external breathing machines sometimes help in that manner as well. One of the areas of management that we look at as well in these patients is as their disease becomes very advanced, we look at end of life care in these patients. This is a condition that will cause a patient to die at a time earlier than they would have died had they not had the disease process. So this is an area where, again, we talk about initiating hospice care in patients at the end of life. And we initiate hospice care in our patients with advanced breathing difficulties, not at just the very end of their condition, but when they are starting to experience significant problems with shortness of breath, when they're talking, when they're walking, if they're becoming more dependent on needing oxygen throughout the day, if they're finding that those medications we talk about are not carrying them through for a number of hours and they have to use them more often. This is the time that we talk about bringing into their health management picture, hospice services as well, because we know that by doing this, we can oftentimes lessen their symptoms or their symptoms of breathing difficulty. There are other medications that we use sometimes to again help their breathing problems. We will provide nursing assistance and nursing help for these patients in their home setting, wherever that is, to allow them to be more functional in the home setting. As well, we give the patient control. We know that a significant number of patients, the majority of patients with advanced lung disease, actually end up dying in a hospital or emergency room setting. If you remember from last week, we talked about with the dementia population and with the heart population, when we ask these folks where do they want to be when it is time for their end of life to occur, the vast majority of patients, about 85% of patients, will tell us that they wish to be in their own home setting, whether that be their home, whether it be their assisted living facility or their memory care unit. That's where they wish to be. We know that in patients with lung disease, only about 17% of those patients are on hospice services when that time comes. The vast majority of patients are not, so they end up oftentimes in an emergency room, and from the emergency room they end up being moved to an intensive care unit. They often end up being placed on life support, and then die in that setting. So with hospice involved in their care, we are able to again allow them to remain in their home setting and allow them to not have to go through all of those invasive interventions. I wanted to finish up by talking about how patients with dementia who also have advanced lung problems can be more complicated to manage. We talk about the use of those medications, and though we talked last week about how many of the medications we use to treat dementia can make heart disease worse, and how some of the heart disease medications can make dementia worse. It's a little different with a lung patient. What we find in the lung patient is not that the medications that we use for treating their lung conditions make the dementia worse, but that the dementia makes it harder for the patient or the patient's family to administer the medications that you would normally use in their lung condition. Patients have to be able to effectively use those inhalers. They have to be able to take a deep breath with the inhaler. They have to be able to hold their breath for a period of time. And because of dementia, many times these patients can't effectively use those devices like they need to, so they don't get the benefit. And even using the nebulizer treatments, where we can sometimes put a mask over their face and help them breathe the mist, because of their dementia, they oftentimes become fearful of the mask and will become very resistant to the treatments that they really need to undergo in order to stabilize their lung condition or to maximize their symptom control. So these are some of the areas where treating the dementia population for the lung disease can be much more difficult to do as well. And those are sort of some of the basic topics that I wanted to talk about with these conditions. And so I'm kind of open for any questions you might have, and we'll go from there. Okay.
Here it comes. Sorry, had to climb over a few chairs. All right. Thank you guys so much, and we'll talk to you all soon. Be safe, and thank you for watching.